Good morning. Welcome to Symposium on whole ale. So this is a very important symposium. It's on reflux, GORD, assessment and surgery. So I am Dr. Chaturanka Petiyagama, a GI surgeon Candy, and this is Professor Niranja Devanarayan sharing the session. And we have two eminent speakers who are expert in this field. So may I ask Professor Niranja to introduce the first speaker.
Good morning. It is my pleasure to introduce Dr. Etsuro Yazaki, Clinical Lead, Upper GI Physiology at Queen's Mary University of London, UK. He's a well-known GI physiologist especially in upper GI physiology studies. Today he will be talking on the esophageal manometry. Over to you, Dr. Yazaki.
Hi, so I'm perhaps the only person, non-surgical, then amongst the invited speakers, but just bear with me some physiological investigations. Okay, so today, what I'm talking about is the role of the physiological investigations, especially before the anti-reflux surgery. Then, first of all, how to diagnose properly or accurately for the gastroesophageal reflux. And the second part is to assess some contraindications. Then the last bit is introducing perhaps 2 or 3 pitfalls which you may have. Okay, so the diagnosis of the GORD, which is perhaps the gold standard is the upper endoscopy, OGD, but historically people still do symptoms and history, like a primary care, then a PPI test, which is just trying to PPI, and endoscopy. But today, what I'm talking about the most is the 24 reflux monitoring. Okay, so this is from symptoms. So of course, the patient representing the regurgitation and the heartburn, these are 2 typical reflux symptoms. Then, however, you can see the sensitivity and the specificity, which is the only 30 to 76% and 60 to 96%, which is really not enough. Then next step will be the GPs will be doing a PPI test. Just prescribing PPI up to 8 weeks, then see the patient improvement of the symptom-wise. Then you can see this study, non-GORD patient and the GORD patient, they are responding almost the same, up to 12 weeks. So which means the PPI test is not really clinically accurate. Then this is the endoscopy. This is the gold standard and very accurate. Okay, then you can detect the erosive reflux disease. However, how about the non-erosive reflux disease? So nowadays, primary care, so like GPs, they prescribe PPIs. Then even we say, please stop PPI a couple of weeks before, but most of the patients, they are not really compliant. So you can see the reflux patient without endoscopic evidence of the reflux. So, today's topics, which is the ambulatory reflux monitoring, which is nowadays the world standard for the combined, the multi-channel impedance and pH, so-called MII-pH. Then to detect the reflux disease in a more accurate way. So this is a bit boring slide, but this is the technology of the impedance. Okay, so you can see the impedance changes for the y-axis. Now the little red line is the impedance baseline, for example, within the esophagus. Then if the impedance drops, which means some liquid, reflux or swallowing liquid happening. Then if the impedance increases, which is the air, like aerophagia or burping, belching. So then if you see the impedance changes, so bolus or reflux coming to the two electrodes, impedance drops. Then while the impedance, not the impedance, bolus, it stays, then cleared, sorry, a little bit wrong, then impedance back to the baseline level. This is the impedance changes according to the reflux or swallowing. Then if you see the real traces, the bottom one, which is the orange color, which is representing the pH, which is the most left-hand side, which is the acid reflux, which is traditionally in the pH method used to detect the reflux event. The middle one is the so-called weakly acidic reflux. Still, if you change the kind of threshold of the pH drop, you can detect using pH only. However, this is the last one is non-acid reflux. As you can see, there are no changes at all in the pH traces. However, you can see the impedance channels. There is a clear evidence, something coming from stomach to the upper part of the esophagus. So, what MRI-pH can detect the non-acid reflux events? Which is you can use this technique to assess the proper assessment of the PPI refractory patient, which can be the surgical candidate. Then second group is distinguish functional heartburn from non-erosive reflux disease. Then the last one is for the pediatric, especially very small baby neonates. Okay, we need impedance measurement to diagnose reflux properly. Okay, so this is an example of the assessment of the PPI refractoriness. Okay, so this study is showing the picking up about 170 patients. They're doing the on PPI. Then this is the result of the MRI-pH study. So you can see the non-acid reflux causing the reflux symptoms while on PPI, which is about 40%. But if you can see the rest of the group, patient representing symptoms, but these symptoms were not coincided with any reflux event, including acid, weakly acid, or non-acid. So you can assess the true refractoriness of the PPI. So this is another study, which is a little bit more specific, but as you can see, this red part, which is the erosive reflux disease, which is endoscopically found. Then this is the non-erosive reflux. Then true NAD is the only 40%. Usually, everybody knows nowadays, true non-erosive reflux disease is very small. Then these two group of the patient, which we'd like to detect. So 15%, which is the part of the esophageal hypersensitivity, which is hypersensitive to not acid, but the esophageal distension or feeling of the non-acidic refluxate. Then the left-hand side, which is the 25%, which is a functional symptoms, which means they are just functional. So probably we prescribe the neuromodulator to relieve the symptom-wise. So this is an example of the neonates. So you can see the pH changes, somewhere, but the never drops below pH 4 because of the diet of the neonates. They just drinking and very frequently with milk, which are causing buffering effect of the gastric pH. Therefore, the pH method itself cannot detect the proper reflux events. So far, we're just talking about how to diagnose the reflux disease accurately. Then now, some of the contraindications to anti-reflux surgery. So using the physiological investigations we'd like to exclude the condition, so-called primary esophageal dysmotility, and also the severe esophageal hypomotility. So primary esophageal dysmotility, because these in early achalasia, patient representing the kind of heartburn and regurgitation. Heartburn is the food is fermented by body temperature, then creating the lactic acid. Then lactic acid causing the kind of heartburn. And the regurgitation is because the food is there, not emptied properly. So when patient changes their posture or doing some straining exercise, then they have the reflux. Okay, so to detect these, so we need manometry, so-called nowadays high resolution manometry, which is 36 pressure channels and 1 centimeter spacing. So you can see the kind of pressure tomography, you can see topography. Then this is the normal esophageal HRM, high resolution manometry. You can see the upper line, which is the upper sphincter. Then you can see the small area, about 2 to 3 centimeter, which is the striated muscle dominant esophagus. Then rest of the esophagus, which is the smooth muscle dominant esophageal body. Then lower line, which is the lower sphincter. So this is the achalasia or achalasia. There are 3 subtypes. Then if you see the X-ray examination, you can see that, okay, you can do the achalasia. But you cannot differentiate type 1, type 2, and type 3, where proximally they say, but manometry is able to detect which types of achalasia accurately. Then this is another types of the esophageal dysmotility, which is a severe hypomotility. So you can see the upper sphincter clearly, then some part of the striated muscle part, but no movement at all within the smooth muscle part of the esophageal body. Then, so far we're talking about the diagnosis and the use of the high resolution manometry. Now, I'm going to introduce some pitfalls. Okay, the first of all, the supragastric belching, then rumination syndrome. Then the last part is delayed gastric emptying. So first of all, the supragastric belching. Perhaps you never heard this supragastric belching, but I'll explain later. So supragastric belching can provoke reflux. That's the problem. So reflux disease usually are transient lower sphincter relaxation. That's the major pathology. However, this supragastric belching can create this transient relaxation of the sphincter. Then treatment is not anti-reflux surgery. Treatment is for supragastric belching, which is usually CBT, cognitive behavioral therapy. Okay, so this is the traditional, classic belching, which is the gastric belching. These are the changes in impedance. You can see the impedance changes from stomach, which is the bottom, to the top, to the upper sphincter. So you can see the both lines going from the stomach, just going through the esophagus. This is the normal, not normal, classic belching. So this is the example of the supragastric belching. So you can see the air coming from upper sphincter, which means the patient is sucking air, not swallowing actually. So this in the sucking is caused by the movement, subtle movement of the diaphragm. Then the air can be expelled very quickly within a second. Then this is the so-called supragastric belching. So if you see the patient with very frequent, almost continuous belching or burping in your clinic, this is the case. Not the gastric belching, but the supragastric belching. Then the problem is this supragastric belching, which is within the circle, may trigger this reflux event. So this reflux event can be treated by CBT, not for surgery. So the second one is rumination syndrome. So rumination syndrome is a rumination. You just eat, the chew going down, but bringing up. Okay, so but the rumination syndrome can mimic the pathological reflux. Okay, something like a postprandial regurgitation or reflux. Then again, the treatment for rumination is also CBT. So this is the example of the MII-PH traces. You can see the top in a black bar, horizontal bar, which is the meal time. Patient is marked. Then after the meal, you can see the many reflux events. I will show you the enlarged one. So this is the one. Okay. So there is a reflux and the swallowing, then reflux and the swallowing. Okay, so this is the repetitive phenomena. This is the rumination syndrome. Then the gold standard diagnosis is using this combination of the high resolution manometry and impedance. You can see this picture. Then some increase in the intragastric pressure, which is this one here. Okay. Then followed by the, some reflux event using the impedance channels. Then you can see the clearance, which is the swallowing, this movement swallowing. This is the rumination syndrome, typical pattern caused by the combination of the HRM and the impedance. Okay, the last one is delayed gastric emptying. Not only just delayed, but severely delayed gastric emptying. And anti-reflux surgery, not curing the fundamental problems. Okay, so this is the gold standard to detect the gastric emptying, which is the gamma camera. But as you know, this involves the radioisotope technetium-99, and also the exposure to the radioactive products, and also the very expensive and the capital and the running cost. So in my unit, we use the breast test, which is a C13 breast test. The idea is the C13 octanoic acid we use, which is only absorbed within the jejunum, then metabolized, then coming out to the blood. Then the lung just filtering this C13, then comes out from your breath. So the first of all, you just prepare the test meal, mixed with the C13 octanoic acid. Then patient just take a breast samples before taking this substrate, and every 15 minutes afterwards, up to 4 hours. So simply you just do the analysis. Okay, so this is the example of the emptying curves, just plotted by the concentration of the C13, which is the X-ray or found within the patient breast samples. Then you can say the half emptying time. Then there is a special formula, which is considering the time to be metabolized to coming up, which is usually pretty constant. Okay, just to summarize, so role of the physiological investigations for the anti-reflux surgery, which is the first of all to accurately diagnose gastroesophageal reflux disease. Then the secondary to assess the some contraindications, which is the primary esophageal dysmotility and severe esophageal hypomotility. Then the last bit is just introducing some pitfalls. The first of all, supragastric belching and rumination syndrome. These are cured by CBT, not by surgery. Then the last one is delayed gastric emptying. Then again, so if patients got a delayed gastric emptying, especially for gastroparesis, which is the next talk, Mr. Kadikamanathan will explain, then anti-reflux surgery will not cure the condition of the reflux. Okay, thank you.
Thank you very much, Dr. Yazaki. We'll entertain the questions at the end of both presentations. Thank you.
I think I'm going to invite the next speaker, with a special note is Mr. Sridharan Kadikamanathan. He's going to talk to us on GORD assessment and surgery with the surgical perspective. So he's a consultant upper GI surgeon in Broomfield Hospital, Chelmsford. He's an expert in anti-reflux surgery, giant paraesophageal hernias, bariatrics, and he was operating esophageal cancers, minimal and invasive esophageal surgery, and now he's much more concentrating on anti-reflux and also giant paraesophageal hernias. Over to you, Sri. And special note, personal note, I think he's my trainer in the UK, and in this Monday we had a SLAMAD's wonderful workshop, and he operated, I think, a nice paraesophageal hernia. So I'm sure that our old surgical trainees might have enjoyed that. Sri, over to you. We are ready to listen to you.
Chaturanga, thank you so much for your kind introduction, and may I thank the Society for the invitation to talk. I mean, this is going to be a slightly different kind of talk in a way. I mean, anti-reflux surgery has been around for a long while. The first ever laparoscopic anti-reflux surgery was performed in 1991, so this is 32 years on. And I think what I want to do is to look at the perspective of anti-reflux surgery in terms of where are we now, and I hope it's slightly thought-provoking on the basis that I've had been operating on for over 26 years on this particular topic. So just to say who I am, I've been a consultant upper GI surgeon for over 26 years. I was initially an academic surgeon, then moved on to set up the cancer center, done over 700 anti-reflux surgery, over 200 paraesophageal hernias, did my PhD thesis on gastroesophageal reflux, and have had many presentations. So in terms of the current status of anti-reflux surgery, what does happen? The patient comes with some form of reflux symptoms such as heartburn or regurgitation, and the patient tells either the gastroenterologist or the surgeon seeing the patient that medicines don't work, and I would like to have surgery so this will cure me. And hence the patient then will undergo some form of investigations. Now, this might, on questioning, he might have had antacids, alginates, prokinetics, and anti-acid therapy in terms of H2 blockers or PPIs, and he would have had maximal therapy as deemed by the attending physician or the gastroenterologist. And of course, most patients are not satisfied, although most patients are satisfied by anti-acid medication, it is not 99% effective. So the thought process in the early 90s was that let's have anti-reflux surgery so that patients do not have to take any form of medication after surgical intervention. And of course, the investigations would involve an endoscopy, manometry, these days high resolution manometry, and 24-hour pH studies. Now this would be the sort of kind of workup you would have when somebody is being considered for anti-reflux surgery. Some of the slides may be similar to Dr. Yazaki's because we work in the same unit. Now in terms of endoscopy, one does an endoscopy predominantly to exclude other diseases. 50% of patients will have some form of endoscopic evidence of gastroesophageal reflux disease. And of course, the symptoms unfortunately correlate poorly with severity of the disease. For example, patients with grade C or grade D esophagitis may not have very little in the way of symptoms as opposed to those with grade A or B or even normal endoscopy. So the traditional manometry was to look at esophageal motility. Is it normal, and is there any evidence of sphincter abnormalities such as achalasia and so forth? And now, of course, we have come to have high-resolution manometry. Dr. Yazaki eloquently showed you the physiology behind it. And the kind of manometer tube looks like this. And the standard esophageal manometry would be showing a normal esophageal motility with a either normal or a hypotensive low esophageal sphincter that relaxes on swallowing. Then, of course, one would move on to perform 24-hour pH studies. And that, of course, may look like this in a patient with gastroesophageal reflux disease. You can see the normal intraesophageal pH is 7, and every time there is a reflux event, it dips down. And as Tom DeMeester did work many, many years ago, if the pH drops less than 4 and it stays on for 4%, the patient is deemed to have pathological reflux. And in the late 90s, when I was starting to do anti-reflux surgery, we would then say, okay, the patient is not responding to maximum medical therapy, has got proven gastroesophageal reflux, let's go on and perform an anti-reflux surgery. And of course, anti-reflux surgery in the laparoscopic era had several of these: the Nissen fundoplication, the Rossetti modification of it, partial fundoplication such as toupee or a Hill's operation. And all these that were done in the open era were also tried in the laparoscopic era. But there are problems. And if you honestly look at your own data, the results are very variable. There are good results and bad results. And there are also concerns about the durability of the procedure. Often the patients are very young, and if one has to do any kind of intervention, that has to be durable. So it's always good to go back and look into history. This was an astonishing series by various people: the anatomical repair, the Belsey, Hills, or the Nissen, and look at the numbers, 5,000 plus patients. We would die for that kind of data these days. Belsey did 1,600, Nissen 3,200, with very little operative mortality, bearing in mind this is in the open era, and look at the success rate, 88% to 92%. Astonishing results. However, in spite of such wonderful results, there was a decline in anti-reflux surgery. I mean, when I was young, we never saw any anti-reflux operation in the open era. There were significant side effects. There were emergence of the potent antiacid medication with very less side effects. Patient thought we would just have a medication rather than any surgical intervention. Then by the 1980s, not many of these procedures were performed. So why is the re-emergence of anti-reflux surgery? There was new technology like laparoscopy, and surgeons thought, why not do a laparoscopic fundoplication? The cynics would tell. And this is my own data. We did about 200 plus anti-reflux surgery when I was a consultant at London Barts, and we published this data, and we showed that if you were to control, with regard to control of acid reflux, we had such very good results. But what we were surprised was that those patients who did not have, who had residual reflux after surgical intervention were absolutely delighted with the results. While some of the patients who had poor, very good anti-reflux, so very good acid suppression, were still complaining of their symptoms. So the question then is surgery better than medicine? There were two studies done by Stuart Speckler in the open era, which showed that fundoplication was better than ranitidine. Of course, PPIs were not available at that time. In the modern era, there was a Lotus study done in the early days of laparoscopic fundoplication. It was 554 patients. It was a 5-year follow-up, which actually, interestingly, what showed was that there was no difference between the two. Hence, the conclusion was that fundoplication was better than esomeprazole because patients didn't have to take any medication. But what is the long-term outcome of fundoplication? There was a study by Stuart Speckler, who in fact did the original study in the open era showing that surgery was better than medicine. Showed that 62% of the surgical patients, even after surgery, continue to take anti-reflux medication. And Lars Lundell from Sweden showed that 25% of the patients experienced significant symptomatic or endoscopic relapse. So surgery wasn't actually perfect. In fact, when patients said, once you have surgery, you don't have to take any medication, was certainly not true. Then, of course, eminent surgeons like Tom DeMeester decided maybe these guys are doing their surgery badly. So they developed these algorithms like, let's have intra-abdominal esophagus, should be a short floppy wrap. Short means how short? Nobody's really sure. And the importance of crural repair. So, hence I said before, length, how short is short, floppy, should we mobilize short gastrics or should we not? In fact, equally randomized studies have shown that whether you divide the short gastrics or not, the results are equally the same. Then wrap, what should you be doing? Full wrap as a Nissen or a Nissen Rosity, or a partial fundoplication like a toupee or door. In fact, again, randomized studies have shown there's no difference in terms of reflux control on whether be it partial or full. Then the crural repair. Is a crural repair necessary? Should it be an anterior repair or a posterior repair? Most of us do posterior repair. And how tight should it be? How do you measure the tight? Now there are technology like endoflips coming on to measure this sort of thing, but how tight is very arbitrary. And of course, if you go back in history, look at Allison's repair from Leeds in the 1700s, he showed that crural repairs broke down 20 years later. What about the complications of reflux surgery? I mean, there are lots. There's less in terms of incidence, but there are two things I want to focus on. The need for revisional surgery. This can be, this is Joel Richter showed that it can be high as 10 to 15%. So what about the reputation of Nissen fundoplication? So the patients can't be sick, and if they're often, what happens is that when they're actually sick, that's when the wrap gets disrupted. They have gas bloat, and they have significant flatulence. Now this can be very troublesome for a young person who has had anti-reflux surgery. And the surgery will have to be redone after 10 years. Now, this is the data that's now coming out. So if you look at the quality of life after fundoplication, first year, fantastic, 90 to 95%. Then as it goes years down the line, there is a revisional surgery, 27.1% failure rate at 10 years, requiring a revision surgery. Now, these are patients who are troubled so much that they require some other intervention. And revision surgery is not for the faint-hearted. My entire practice now is revision surgery. And again, this is again sort of reflected by the number of fundoplications done. In the year 1999, 2000, that was my kind of time when we were doing lots and lots of fundoplications. Now it's coming down. People are doing less and less of that. And complications are being recognized, and people are looking at more and more about quality of life. The complications are so much so that now there is a classification for complications. You've got type 1 disruption, the type 2 disruptions, type 3 disruptions, and the type 4 disruptions where this entire wrap is within the chest. The latter is the most common problem. Up to 80% of patients have this, and this is one requires revision surgery. So, what is the long-term outcome after anti-reflux surgery? Satisfaction rate is 95% at 1 year, but it drops off. Patients are on medication, 60 to 80% of patients. So this is some kind of medication that requires either to treat what they have perceived heartburn or some other side effects such as diarrhea or flatulence and so forth. And 40% of patients still remain on anti-reflux medication, despite what may be deemed as successful surgery. So, the challenge, I think, nowadays is that anti-reflux has been around for a long while. You see how we can improve the outcome. I think the selection of patients is paramount. That's where people like Dr. Yazaki come in, because they can have sophisticated esophageal and gastric function studies that just might help us to achieve that. They could also exclude patients who might not do well. So Dr. Yazaki showed lots of these impedance and MRI recordings. I was going to focus on one or two just as an example. So this is sort of color coding, talking about purple is low impedance, that means liquid usually, and blue is high impedance, which is usually air. And one can superimpose impedance with manometry that gives more functional results such as this. For example, here you can look at not only the bolus transit, but also what happens to esophageal manometry at the same time. And similarly, red means acidic and blue means non-acidic pH. This is just to show a normal tracing where the patient is swallowing, but there's no change in esophageal pH. And the liquid clears very well. And here you get a retrograde flow of bolus, but you can also see the drop in pH. Therefore, this particular patient is having acid reflux. And here, what we call a non-acid reflux, where there is a reflux event happening, but the pH is normal. So this patient having a non-acid reflux. So this is one of the things Dr. Yazaki alluded to earlier on. I don't think he showed this particular. So this is a patient who is having supragastric belching, and you can see the air being sucked in, the blue at the front, sucked in, and then the patient refluxes. So the patient here is refluxing because of supragastric belching, not because the patient got pathological gastroesophageal reflux. And these patients are extremely unlikely to do well following surgical intervention. And they are better off being treated with CBT and so forth. Again, you want to exclude primary esophageal motility such as achalasia and scleroderma, which again Dr. Yazaki alluded to, because it is very common to do anti-reflux surgery on patients with achalasia without pH and manometry, because as he said, food fermentation can cause raised pH. Sometimes, therefore, the patient might complain of acid reflux, but the esophagus does not distinguish between acid from fermentation of lactic acid or hydrochloric acid from the stomach. And the more important one is to exclude rumination syndrome. Now, these patients have postprandial reflux, and they were so-called the volume refluxes in the old days. And you tend to do surgery for these people, their life is a misery afterwards. And of course, important to exclude gastroparesis, because these patients not only have poor outcome, they got severe gas bloat after surgery. So, in real terms, getting the optimal results remains a challenge. One of the other aspects is that patients with severe preoperative reflux tend to have severe postoperative reflux even after frontal plication sometimes. The other difficulty is, especially in functional surgery, there's no correlation between subjective and objective for outcome following surgery. Now, you may ask that a lot of the patients who are on anti-reflux surgery after anti-reflux medication after frontal plication, if you actually measure their pH, that's normal. But they are comforted by anti-reflux medication. And a lot of the patients who may have pathological postoperative reflux are commonly asymptomatic. And of course, the durability of the procedure is questionable. I'm doing revision surgery on patients I did 15 years ago, including my theater sister, whom I had to operate recently, 15 years after original surgery. Many thanks.
Thank you very much, Mr. Kadikamanathan, for your excellent talk. So if you have any question, it's time to ask. If I start with one question from Dr. Yazaki, so what are your pre-operative, pre-preparation for pH and manometry when someone refers to you? What advices or what prerequisites you expect them, how long these medicines to be off, etc. Because there are requirements from your side to get a good report, because otherwise this report won't help the surgeon to decide on surgery.
Okay, so the ideally 7 days off PPI completely. If somebody is on famotidine or ranitidine, we usually ask the 3 clear days. Then any other medication like Gaviscon or sort of very short-lasting antacid, we just ask the patient from the previous night. So that's their medical-wise. Then some other, implications, but it's really depending on the patient. Then our impression, our experience is the most of the patient PPI, complaining PPI, refractoriness, which actually they don't have reflux. That's the majority of the cases.
Okay, thank you. In addition, so there are other concerns like on PPI and off PPI also you can do the test. So what are the implication, what are the importance of doing that?
Okay, this is the many people talking about. Then we usually do the off PPI for the very first time. Then if you identify the clear evidence of the reflux, then try to do the on PPI to test the PPI refractoriness. But the exception is, of course, patient with severe esophagitis or Barrett's. Of course, you don't have to do the pH study, but to exclude possible esophageal dysmotility, so we do the manometry.
Okay, thank you. Sri, I think I will, as usual, there are many concerns like this, peptic ulcer disease and reflux are 2 different pathologies. So our aim of doing anti-reflux surgery on a patient to take them off PPI. So, but, if they are having concomitant peptic ulcer disease and also reflux, so in that scenario, how does it help? So will it help to, help us to off them PPI? So should we continue PPI on the patients with peptic ulcers?
I think peptic ulcer disease is a different pathology altogether, and you'll have to treat that separately. So, I mean, with regard to reflux, is acid in the wrong place rather than excess acid? Because a lot of work has been done on this. Patients who have gastroesophageal reflux disease do not have excessive acid secretion. So I think if you have concomitant peptic ulcer disease, you treat that separately.
Any questions from the audience? I have one question for Dr. Yazaki. Okay, we'll wait.
Thank you. Actually, we as surgeons are actually interested to hear from them. And plus, the surgeons who are actually proponent of gastric reflux surgery are sharing very frank opinion that they are all controversial. I'm a surgeon myself, and more and more people will be actually diagnosed with gastroesophageal reflux disease. We are actually confused now. Maybe students, residents, fellows, we need some more sort of a guideline based on your physiological, maybe many countries do not have those. For my non-surgical advice, I would just like to know, what is that cognitive behavioral therapy? Who provides that? And because we surgeons don't really know where this cognitive behavioral therapy, which we have a positive, I feel there's some positive indication. It might benefit because many things are very mental up there and not really objective. So thank you.
Right, so CBT is, to be honest, very difficult to perform. But we do the including the clinicians, but usually we ask the so-called clinical psychologist people, which is a very small group of the working on the NHS. Then we usually ask. So what they do is the visual feedback. So if they do the suprachiasmatic belching, for example, they can see the picture, air is coming inside your esophagus, then coming out. So then during that event, what they feel or what they do, then we just explain, this is the straining. You can see this pressure increase within the stomach. Then sort of things, so you can feedback. So this is the CBT. But again, yes, there are very limited center be able to perform this kind of procedure to the patient.
One more question from Dr. Yazaki. I'm a surgeon, Bhavanta. Now, two questions actually. What is your opinion about acid pocket theory and the reflux? Can we use medicines to minimize the concentration in the acid pocket so that the necessity for the surgery can be further decreased? Number one. Number two is there any relationship between H. pylori and reflux? Earlier we thought H. pylori will reduce the reflux. There were some papers coming up. Have you found any data on this?
For the second question, could you repeat it again?
Yeah, second question is there any relationship?
H. pylori. Yeah.
Yes.
Sorry. Yeah.
Thank you.
Okay, so the first question, the acid pocket, yes, but acid pocket is usually doing the or causing the really severe pathological reflux with the combination of the hiatus hernia, which is more than 3 centimeter. Because more than 3 centimeter hiatus hernia, acid pocket may be within the porch of the hernia. But otherwise, yes, acid pocket is very important findings and concept, but with hiatus hernia, we usually talk about the more specifically. Then the second question is H. pylori. Okay, so after the H. pylori, yes, we can see the increased number of the reflux cases, but we don't pay particular attention for because if you compare the outcome from the eradication of the H. pylori against the risk of the reflux, the eradication of the H. pylori is more important clinically. So in that sense, but we always talk about if you recently or in past they had eradication therapy, then yes, we do consider this, as one of the cause of the reflux.
Can I ask one question from your Dr. Yazaki? One of the most difficult things is to diagnose NERD patients with non-acid reflux. Usually we go by number of reflux events, but there's a lot of controversies of the cutoff values for reflux events. What do you practice in your laboratory?
Okay, yes, it's a good question. So there is no established cutoff point for the non-acid reflux, but how we decide the non-acid reflux is using the reflux symptom correlation. Even the small number of reflux, but definitely causing the patient symptoms, then it's those patient is the patient with a non-acid reflux disease, so non-erosive reflux disease. But but there is no established cutoff point.
Thank you, Dr. Yazaki. I think it's very thought-provoking. You can see earlier historically when we see a hiatus hernia, next step was to go for surgery. And that was a tradition in the history. And now more and more questions, going toward the physiologist. So that is the great thing about surgeons. Now we are turning into different level. So I think that's what should happen. Sri, can I ask a question on, we are trying to do anti-reflux surgery. So what type of anti-reflux surgery, what do you think better? I mean, Nissen or Toupet, or how do you decide on that generally?
I think there's no consensus on that at all. I mean, the randomized study shows Toupet is no different to Nissen in terms of either the reflux control or in terms of side effects profile. I suppose as surgeons, we feel comfortable if somebody's got slightly delayed gastric emptying, we would rather do a toupee rather than nascent fundoplication, but there's no real scientific evidence for that. I think the more, so when I gave this talk, this, by the way, excludes paraesophageal hernias. It's got nothing to do with paraesophageal hernias, and the acid pocket is very much more in paraesophageal hernias rather than simple reflux. In terms of, I think the worry I have is the durability of the surgery and the fact that a significant number of patients are still on medication. Now, initially when anti-reflux surgery came about, it was thought to be replacing medical therapy. And the reality is not that. That bothers me as a starters. And the second thing is that as you get older, you see the patients coming back to you whom you did surgery 15 years ago with rap disruption, et cetera, and that's why, recently we are going to publish the 20-year follow-ups, because nobody looks at patients for this long, up to 5 years or so, and then the patients go away. And this again, look at the old data, we had thousands and thousands of patients with great success initially, but nobody really knows what happened to these people. So durability is important, and the fact that why these patients still have to be on anti-reflux medication after successful surgery is questionable. So in my advice is that when people do, and this is only my advice, but it's a more pragmatic thing, is that when you counsel the patients, ultimately, of course, we make a decision together, is that you have to talk about the side effect profile. You have to talk about the possible complications, but more importantly, the durability of the procedure. If you're going to operate on a 30-year-old with anti-reflux surgery, you better be ready for revision surgery come 40 or 45 years.
Okay. Can I ask one question from Dr. Stree? How frequently do you see patients with GORD patients with gastric emptying problems, gastroparesis?
So I think a lot of studies have been done on this. I mean, a third usually, 33% of the patients.
So it is very frequent.
Yeah, it is frequent, yes.
So next question, Sri, I think for all the trainees and surgeons, because we are trying to operate patients. So now the gastroenterologists, they have found many endoscopic options, and also links coming into the picture in the US. So many RFA, Strata, Endofix, many devices coming. So will it replace surgeons?
I don't think so. I think having been involved, my original PhD thesis was on endoluminal anti-reflux surgery with Paul Swain many years ago. I think these things are not taken on. And similarly, links have got their own problems. I mean, links was a great thing about 5 or 6 years ago when there were several papers talking about success. And the last DW in 2022, there were 14 presentations on complications of links. So I'm not entirely sure. I mean, again, we are revisiting history in terms of angel cheek prostheses and so forth. Where, astonishingly, the one randomized study that compared nascent fundoplication versus angel cheek prostheses, guess what was the better operation? Was the angel cheek prosthesis. But it had erosions, all sorts of other side effects. So I don't think it will replace surgeons. But I think the anti-reflux surgery has got a place. I'm not saying that it shouldn't do it. What I'm saying is that it has got to be taken into context, and the patient has to be properly counseled before surgical intervention.
There are many. Right.
Okay, thank you very much for a very interesting session. Professor, you just mentioned that most of your practice right now is doing revisional surgeries. I was just interested in knowing what your results for revisional surgeries are.
The results of revisional surgery are too early to say. But what's interesting is that when we do revisional surgery, we actually take down the fundoplication and do the crural repair and do a gastropexy rather than redo fundoplications. When you do redo fundoplications, I've only got a handful of patients. They recur again. I suspect this because partly when they have got hiccups or when they have trying to be sick or retching or food poisoning, then the rap goes back up, I guess. I think again, these are anecdotal, they are not scientific. One of the patients came and thanked me for doing revision surgery because he could eat steak finally, and his life was wonderful. So in terms of revision surgery, I don't know the results because we are only seeing them now, and I get patients from the southern part of UK, quite a lot of them. So we'll be able to find the results in 5-6 years' time, I guess. It's too early to say the long-term results on that.
Another point, Sri, what I want to make is because physiology studies, if you look at Sri Lanka, only 4 or 5 centers being carried out. So a lot of pressure came from, surgeons everywhere. So they have to have a waiting for a long time to get a physiology study done. So in that scenario, what we thought is it's not something killing that patient urgently. I mean, it's not a malignancy. So therefore they can wait, they can refer and make sure the patient comes back to them and also provide them, mental support because they want a quick relief. All our patients need 1-day relief of the symptoms and next day they want to get the surgery done. So they somehow get the surgery done. Then after that, they don't get better. Then only they realize something has gone wrong. So that attitude has significantly changed and all the surgeons now I think, refer to a particular center and get them back and offer the best treatment for the thing. So that concludes the session. I think we are reaching the last bit. So may I invite Professor Niranga Devanarayana to give the token of appreciation to these two eminent speakers. So may I ask Dr. Yazaki to come forward and take the token of appreciation on behalf of College of Surgeons of Sri Lanka and the Council. Thank you very much for your contribution coming all the way from UK and educating us. Then next is Mr. Sridharan Kadikamanathan. It's over to you, Sri. Thank you so much. I think it's a great session. Thank you very much, Professor Niranga. And we were able to make a very good discussion. And that is the most important thing. Rather than just a talk, we were able to make a good discussion. Thank you very much.